A very good morning to all the delegates. I'm Dr. Manusruth from Yashoda Hospitals, Hyderabad, India. I would be speaking on balloon Eustachian tuboplasty, fairly a new procedure for ENTs. So why do we need this? Because Eustachian tube is the black box of otology. All the problems in the ear is because of this tube, and we don't know why it's happening and how to deal with it. It could be a simple effusion to a perforation to even a cholestotome. And in Eustachian tuboplasty, we deal with the cartilaginous part of the Eustachian tube up till the isthmus. These are the two muscles which act in opening the Eustachian tube, levator villi palatini and tensor villi palatini. The dysfunction in Eustachian tube could be of three types. It could be obstructive or patulous, or it could be barrow challenge for patients who have the problem only during testing conditions like flying or scuba diving. And these patients will be normal at normal ambient pressure, but when they have a challenge like pilots or air hostesses, frequent flyers, that time they can have ear pain which lasts for several hours even after the flight journey is over. The other group of patients are patients with obstructive pathology who cannot equalize the pressure, and they could have a short-term problems like an effusion or a retraction, or may lead to long-term issues like atelectasis, perforation, cholestoma, and other ear disorders. Fairly, this is a common problem in pediatric age group. Adults also, it's around 1 to 5% the incidence of Eustachian tube dysfunction. Pathogenesis could be because of chronic infections, allergies, reflux, or any primary mucosal disease, chronic sinusitis, or dysfunction of the dilation mechanism, or some obstructive mass like an adenoids. So what can be done? Now we have only steroid nasal sprays, antihistaminics. We really don't know whether they work. Ventilation tubes are a sure shot solution to these problems, but have their own set of issues like infection, obstruction, extrusion of the grommet too early can cause permanent perforation, and often we do septoplasties which help in ventilation. But does it work? We really don't know. And this is where Eustachian tuboplasty comes into action. So who is our patient and when do we do it? Patients could present with symptoms of ear block, fullness, tinnitus, heaviness, or patients who cannot pop their ears, or barrow challenge patients. And how do we assess? Now there is no single diagnostic test or assessment tool which can tell us that yes, this is a problem with the Eustachian tube, but it is a combination of the history, what we see on otoscopy, impedance showing a B-type or C-type curve, endoscopic examination, and most importantly the Eustachian tube questionnaire. This questionnaire asks 7 questions which all are related to the pressure and discomfort in the ear. It is scored from no issue to severe problem, and any score above average of all the scores is taken. If it is above 2, then it is considered as abnormal. And how can we assess through endoscopy? It is advisable to use a flexible endoscope so that we can see both the orifices, Eustachian tube orifices, in a single scope examination, and we can try to see as deep as possible and also rule out any extrinsic issues. The endoscopy will also help us in assessing the axis, whether there is a deviation or hypertrophied turbinates, which may prevent us from doing a Eustachian tuboplasty. And you can see here in slow motion how the muscles are contracting and making the Eustachian tube open. With a flexible scope, you can see deeper into the Eustachian tube, even up to the isthmus. Now, in a differential diagnosis, we have to consider patulous Eustachian tube because it's a strict contraindication for dilation. Patients could have TMJ disorders. This is because the muscle is very close to the temporomandibular joint. They could have other issues which cause ear block like suprarenal dehiscence or inner ear hydrops. So now who is a patient who needs this? Patients who are barrow challenged, patients with repeated grommets, with retraction pockets, with effusions, repeated effusions, or post-radiation patients, pediatric patients with repeated tubes. It can also be combined with other procedures like a nose procedure, adenoidectomy, or even with tympanoplasty, or it can be also combined while putting a grommet. And how do we do it? Coming to the actual procedure now. Basically, it's just two simple steps. We insert and we inflate. So insert and inflate. Insert is for 1 to 2 minutes. We have to inflate it to 10 to 12 atmospheres. Now the balloons are designed in such a way that the length does not cross the cartilaginous part, stops at the cartilaginous part, and that's why there is no risk to the carotid artery, which is actually related to our bony eustachian tube. That is why in today's date doing a mandatory HRCT is not required before doing a Eustachian tuboplasty. Now how does the set look like? You have an insufflator. This can also be borrowed from our cardiology colleagues. It is the same one. And you have a cannula with an angle around 45 degrees. Then we have the balloon catheter itself. It has a metal stellate to support the catheter, and the design is still evolving as we do the procedures. The stellate can be removed, loaded onto the cannula, and the insufflator can be attached to the balloon. Now this one is from the company Meril. There's another one available in India from Smith and Nephew. Now how do we access? We can take a contralateral access if there is a bad deviation, or we can do an ipsilateral access. This is more convenient and more easy to do, or even a access from pharyngeal side using an angled endoscope. Here you can see the cannula, and here you can see the balloon which is inflated. And the procedure can be repeated if you are not satisfied with your first attempt. Here you can see the video which is describing the actual procedure. Now this video is an unedited video doing it at 2x speed. You can see that we have placed the cannula loaded with the balloon and gently passed into the Eustachian tube. This is the left side is what we are seeing, and you can see here that the balloon catheter has passed in and there is a black mark over here, so it is advisable to reach up to the black mark, which is a few away from the end of the balloon. This will avoid inflating the balloon in the catheter itself. When you inflate, you can see some mucopus coming out over here, and the balloon sometimes can get pushed out because of the force of the inflation, and you have to maintain some amount of angulation and force on your cannula so that the balloon doesn't get pushed out. Initially when we insert, it is important that there is no bleeding, because if there is bleeding, it indicates that there could have been some mucosal injury, and that time it is advisable not to inflate the balloon, because you could be in the wrong track, and it can cause further damage to the tissue and can also lead to scarring of the Eustachian tube orifice. Now this is one dilation which we have done. You can see a lot of mucopus coming out which has been suctioned out. Some amount of dilation has happened, and the procedure can be repeated. So we put the catheter back in again. Now this time it is much easier for the catheter to pass in, and then we inflate. The same procedure is repeated, and we do this for around 1 minute at a pressure of 10 bar, and your assistant would be doing the insufflation. It is important to note that in one of my cases, we saw a patient going into bradycardia, and my anesthetist immediately noted it when the balloon was insufflated. As soon as we deflated the balloon, the heart rate went up again. Although the patient didn't have any bony canal dehiscence or an abnormal carotid artery, we observed this. So really, some patients there can be issues like this, and our anesthetist has to be aware. Now coming to some complications which can happen, as I mentioned, there can be minor bleeding during insertion, but if the bleed is too much, then it indicates that you have gone into the wrong false tract, and it is advisable to withdraw and abandon the procedure, because you don't want any scarring in the eustachian tube. As I already mentioned about internal carotid artery injury, this could happen if the balloons are much longer, but today's date we don't see it. And patients can have emphysema if you have gone to the false tract, and patient does Valsalva after the procedure, he can have emphysema. So we ask the patient to avoid Valsalva or blowing for a couple of days if we know that we have gone into the false tract. So what is exactly happening? When we insufflate the balloon, we are going to push all the lymphocytes from the submucosal layer out into the vascular channel in the lymphatic channel, and thereby decreasing the thickness of the submucosal area and increasing the lumen of the Eustachian tube. Now this has been proven by histopathological studies by Dennis Poe et al., who's like the father of Eustachian tuboplasty, I would say. In our series, we have done many cases, more than 80 cases, and done for all sorts of indications like Barrow challenge. Sometimes we have combined it with Grome for persistent effusions, combined it with tympanoplasties in cases of revision tympanoplasties. Most of our tympanoplasties are done as an endoscopic procedure, so it becomes an add-on and an easier way to do a tuboplasty and followed by tympanoplasty. So it is advisable to do the tuboplasty first and then by tympanoplasty. It can be done for patients with retraction pocket. Post-RT patients, 2 patients we have done it. Here you can see one of the patients whom we did, and you can see how the pus is coming out of the Eustachian tube orifice. There's a lot of tubal edema over here. This is another case example which you can see that in this patient, the both the ears had a retracted drum, grade 3 to grade 4 retraction. Right side you can see that already the IS joint is partly eroded, and left side it looks intact. So first we did Eustachian tube dilation for him, both sides. He also had a adenoid which was also removed, small chunk of adenoid, and then after the dilation this is what we saw on the left side. Now you can see that most of the drum has come up except this small pocket in the posterior superior area. So this had to be excised and we placed a cartilage graft there. So Eustachian tuboplasty combined procedures are really helpful. Now one small indication about patulous Eustachian tube. You can see here in this video how the patient, when he's blowing, how the tympanic membrane is moving, and also when he starts breathing normally, just a normal breathing also causes the posterior superior part of the drum to move. It is important that these patients are not ballooned because it can increase their symptoms, and they are usually managed by either loading the TM with the cartilage or doing tubal injections to increase the bulk of the Eustachian tube. Is balloon Eustachian tuboplasty better? Shall we do it or not? Is a question in many of our minds because it's a relatively new procedure. But there is enough data now. This was the main study which was done for the FDA approval of the balloon, in which more than 50% of patients the tympanogram normalized. Now there has been clinical consistent statement by the American Academy, and also by one of the academies in Spain also has given a consensus statement. This is available online, you can go through. One of the important statements from the Spanish guideline is that they have advised it for patients with tympanoplasty failure. So a lot of us have these patients who have failed tympanoplasty. We don't know the reason why it has happened. So combining tuboplasty in such patients could be give us better outcomes. Now coming to the outcomes, Eustachian tube question scores can improve more than 90%, but usually we tell the patient there is a 50 to 70% chance for you to not have these symptoms again, because it's more of a subjective symptom. There have been studies on concurrent tympanostomy tube placement and tuboplasty. We have also done for many patients. It can be done with patients who got chronic rhinosinusitis, combine the procedure. Can be done in patients with myringoplasty. We can also do in patients who with tympanoplasty, we can combine the procedure. Now even pediatric tuboplasty is indicated, and slowly there has been comparative studies for patients, pediatric patients, to use tuboplasty as the first line of treatment in children with otitis media, giving good results, and maybe this would become one of the first line of treatments in the future as more data comes on this. Key takeaways are: it is an effective procedure for obstructive pathology, but case selection is very important. You can combine with other procedure very easily, especially if you are doing endoscopic work. Thank you, one and all. Thanks for listening.